I'm going to be performing an evaluation of the thoracic and lumbar spine. For the first part of this evaluation, we're going to go over the history. For this, you're going to ask them if they have any previous history of a spinal or back injury or issue. You're also going to be asking them where their pain is, if they can pinpoint one spot, what type of pain they're having, if it's sharp, shooting, dull, and also if they're having any radicular symptoms, so if they're having any numbness or tingling down the legs. Next, we're going to move on to the inspection portion of the exam. So for this, since our patient's already sitting, we are just going to be looking at how she is sitting. And with this, we can come to the side and we can look to see if she has a lordotic and then a kyphotic and then another lordotic curve in her back. These are the normal curvatures of the back. Next, we can have her stand up. We can have her face that wall. And then with this, I'm going to lift your shirt up. We're going to be looking at the spine, and we can follow it down to make sure it goes in a straight line. We can also have the patient bend forward. And with this, we can see the spine more prominent, and we can make sure it's going in a straight line. We can also be looking at the scapulas to see if one is raised over the other. This would be an indication of scoliosis. With scoliosis, you would see the spine come to a curve at the end. And then also looking at their back, you're going to be looking for any skin folds and also any skin markings like cafe au lait spots. We can then also be looking at our patient's gait. So if you want to just walk to that table and then walk back, we can be looking at how their hips are moving as well as how they're holding their upper body. And then next, we are going to be looking at their chest shape. And so for this, we're going to be making sure that there is nothing coming out, making sure it is not caving in. So when the chest comes out, that is called barrel chest. And when the chest caves in, that is called pigeon chest. And next, we can have the patient sit on the table. And now you can also look at their breathing patterns. And so you can look at this from the front as well as from the back, and you can see if there are any hitches in their breathing pattern. This might indicate pain as they're filling their lungs up and they're increasing their intra-abdominal pressure. Next, we're going to be moving on to the palpation portion. So for this, you can have the patient lying on their back first. And so with them on their back in this supine position, you're able to palpate the iliac crests, and then you're also able to palpate the pubic symphysis. So with this, you're going to ask the patient to put their hands on top of each other and put them where the button or the zipper on their pants would be, and then you're going to apply overpressure down, and then they can report to you if they feel any pain with this. Next, you're going to have them flip over onto their stomach. And with this, you can start in the thoracic spine and you can palpate each spinous process. While you're doing this, you're also going to be looking for a step-off deformity where as you palpate, where you expect to find the next spinous process, you don't find it there. You can also be performing a spring test, which is where you just push down on the spinous process and you're looking for how it is springing back up. And this is looking for hyper or hypomobility. Next, you can also palpate the supraspinous ligament. This connects each spinous process to the next one. While palpating along the spine, you can also palpate the transverse processes along either side. And these go all the way through the lumbar spine. Next, we can also palpate the PSIS. And I'm going to lift her shirt up again. We can also look at the erector muscle tone along her spine, making sure one isn't harder than the other, indicating a muscle spasm. We can also look at the paravertebral muscles. So these are going to be connecting your spinous processes to your transverse processes. And so you can just go from spinous process to transverse and then back to spinous process. We can also be palpating the traps during this time. So only the middle and the lower traps connect to the thoracic and lumbar spine. So we can be palpating the middle as well as the lower. Next, we're going to be palpating the ischial tuberosity. So with this, you're going to use the palm side of your hand and you're going to push up and you're going to feel a bony block, and that is the ischial tuberosity. Next, we're going to be palpating the sciatic nerve, which is just medial to the ischial tuberosity. We're also going to be palpating the median sacral crest, as well as the gluteal muscles. So first we have gluteus maximus, and that is the most superficial. We then have gluteus medius, which is palpable along the lateral aspect. And then finally there's gluteus minimus, which is not palpable. We also need to make sure we're palpating the costovertebral junction. So that is where the ribs meet the spinous vertebrae. And so with this, you can just go along each one, palpating the ribs. And then you want to do this bilaterally. Next, we can assess the patient's range of motion. So for this, we're going to have them stand up. And first, you can ask them to bend forward and touch their toes. Okay, and then next, you can ask them to stand up and extend as far back as they can. Good. And then you can also ask them to run their hand down the side of their leg as far as they can go, looking at side bending or lateral flexion. And then you can also ask them, as they keep their hips still, to rotate to one side and then to the other. Good. So that was the active form of the ranges of motion. You can also do this passively. So for passive range of motion, we can just have you standing for right now. And then for passive, you're just going to passively move them into extension, okay? And then you can passively move them forward, okay? And then you can also passively rotate them, good. Good. Then you can also passively laterally flex them, good. Good. Okay, and then next we can look at the dermatomes, myotomes, and reflexes. So for this, you're just going to have the patient sitting on the end of the table. And first we're going to be doing dermatomes. So for this, we have L1, L2, L3, L4, L5, S1, S2. Next, we can perform the myotomes. So with this, for L2, they're going to be going into hip flexion, so they're going to bring their knee up. They're going to hold this as you apply a resistive force, okay? And then for L3, that is knee extension, so you're going to put them in slight extension and then push them into flexion. Then for L4, you're going to put them into dorsiflexion and try to push them into plantar flexion. And then for L5, you're going to be doing great toe extension and you're going to push them into flexion. And then for S1, it is eversion as well as plantar flexion. So we can put them into eversion and then try to push them into inversion. And then for plantar flexion, we can have them stand up and we can have them stand on their tippy toes, and then we can push down on their shoulders. Then for S2, we're going to have them lying on their stomach on the table. And with this, we are going to put them into knee flexion, and we are going to be pushing them into knee extension. Next, we're going to be doing reflexes, so they can again come sit at the edge of the table. For the patellar tendon reflex, this is the L4 reflex, and you're just going to find the patellar tendon. And strike that until you see the knee extend. And then for the S1 reflex, that's the Achilles tendon. And so for this, you're going to grab the bottom of the foot and strike the Achilles tendon. And for that, you're looking for a slight plantar flex motion. Next, we can begin the manual muscle tests. And so for this, we can start with rhomboids and levator. So you're gonna have the patient lying on their stomach. And then I'm gonna have them scoot closer to me. And then you're going to put them in the, what we call the chicken wing position. So you're going to be putting them in shoulder extension, elbow flexion. And then you are just going to be pushing them down towards the table. Good. And then that tests rhomboids and levator. We're then going to be testing the middle and lower traps. So for this, their thumb is going to be facing up. They're going to hold this position as you push them down. Good. So that was for lower traps. For middle traps, you're just going to bring them out to the side and then push them down again. And you're going to be testing all of these bilaterally. And then to test the lats, you're going to bring them into your shoulder extension, and then you're going to be pushing down as they resist you. Good, you can relax. And then next we're going to be starting the special test portion. So with this, we are going to start with the Valsalva test. And so for this, the patient can sit up and they can make a fist with their hand, then bring it up to their mouth and blow into the fist. Okay, good. This is going to be testing for a herniated disc. Another test you can use for a herniated disc is going to be the Wells straight leg raise. And so for this, you're going to have the patient lying on their back. And you are going to passively raise them into hip flexion. And with this, a positive test is going to be painful on the opposite side of the leg you're raising. Next, we can perform Koenig's test. This is testing for nerve root impingement. For Koenig's test, we are going to, again, perform a straight leg raise. Then you're going to bring them up. Once they feel pain, you are going to bend the knee, and this should relieve their symptoms. If they do not have pain, you can then begin with forward neck flexion. So you can bring their neck up, and they can hold this position. And you're then going to perform the passive straight leg raise again. And then this should, if it's a positive test, this should increase their symptoms. Okay, relax. Another test for nerve root impingement is going to be the slump test. This is where the patient's going to sit at the edge of the table. And they're going to begin with forward neck flexion, followed by forward trunk flexion, followed by knee extension, and finally ankle dorsiflexion. Okay, relax. A positive test would be pain or radicular symptoms down the leg. Finally, for nerve root impingement, we can look at the quadrant test. For this, you're going to have your patient stand up, and you're going to place them into extension, side bend, and then rotation. And this will be able to pinpoint where their pain is. Next, we can do Milgram's test for a disc lesion. For this, they're going to be lying on their back. And then they are going to actively raise their legs up. They're going to hold this position for 30 seconds. You can bring them back down. And for this, you're looking to see if one leg drops. That would indicate a positive test. Next, we can do the straight leg raise for sciatic nerve compression. For this one, you're again going to perform a passive straight leg raise. If you're able to get to the end of the motion and it is not producing pain, you can then apply forced dorsiflexion, which would, if it was a positive test, which would produce their symptoms. Next, we can do the femoral nerve stretch test. This is also looking for a disc lesion. So for this, you're going to have them lie on their stomachs. And you're going to put them into knee flexion and then hip extension. And this is again going to produce the pain and radicular symptoms if it is positive. Next, we're going to perform tension sign. This is as well for a disc lesion. For this, you're going to have the patient lying on their back. And for this, you're going to be putting them in 90 degrees of hip flexion and knee flexion. And while you palpate in the popliteal space, you're going to be pushing them into knee extension. If this was positive, it would produce the pain and radicular symptoms. Next, we're going to be doing the single leg stance for spondylolisthesis. So for this, you're going to have the patient stand up. And you're then going to have them stand on one leg. You're then going to passively move them into extension. And then a positive test would cause pain and radicular symptoms. You can lie back down. And finally, the last thing we're going to be testing for is sacroiliac dysfunction, also known as SI dysfunction. The first test we're going to be doing is Faber, which is where you put the patient into hip flexion, abduction, and external rotation. You're then going to stabilize on the opposing iliac crest and then push down on the knee. This, if it is positive, is going to cause pain along the SI. Next, we're going to be performing Gainsland's test. This is where the patient is going to scoot towards me. They're going to bring this leg to their chest, and then this leg is going to be dropped off the table. This will, again, if it's positive, produce symptoms in the SI joint. And lastly, we're going to be performing the long sit test. So you can scoot back to the middle. And for this one, this is checking their pelvic alignment. And so you're going to hold the patient's ankles and put your thumbs right under their medial malleoli. You're then going to ask them to sit up. And you're going to look at how the malleoli line up. If they line up evenly, that means that there is no dysfunction. If one is higher than the other, that can mean that the pelvis is rotated. You'd also want to check for a leg length discrepancy when you do this.